Introduction to cardiac function. The atria and ventricles contract and relax in an organized fashion to circulate blood throughout the body. The cardiac cycle has two phases. Systole, diastole. Systole is the contraction phase when the ventricles squeeze blood out to the body and lungs. Diastole is the relaxation phase when the ventricles fill with blood. Each heartbeat creates the familiar lub-dub heart sounds. Cardiac output. Cardiac output is the amount of blood ejected from one ventricle in 1 minute. Normal cardiac output in a healthy adult at rest is 5 to 6 liters per minute. Formula: cardiac output equals stroke volume times heart rate. Stroke volume is the amount of blood ejected from one ventricle with each heartbeat. 3 factors affect stroke volume: preload, afterload contractility. Hypertension increases afterload because the heart pumps it against higher pressure. Contractility is the strength of ventricular contraction. Poor contractility decreases cardiac output. Example: heart failure weakens contractility. Heart sounds. S1 is the first heart sound called lub. This occurs when mitral valve closes, tricuspid valve closes. S1 marks the beginning of systole. S2 is the second heart sound called dub. This occurs when aortic valve closes, pulmonic valve closes. S2 marks the beginning of diastole. S3 and S4 are abnormal heart sounds. Murmurs are whooshing sounds caused by turbulent blood flow. A pericardial friction rub is a grating sound heard with pericarditis, usually along the left sternal border. Electrocardiogram basics. An electrocardiogram, or ECG, records the electrical activity of the heart. Depolarization is the electrical impulse that causes the heart muscle to contract. Repolarization occurs when the heart muscle relaxes. ECG components: P wave, atrial depolarization; PR, interval, measures conduction from the SA node through the AV node; QRS complex, ventricular depolarization; ST segment, occurs after ventricular depolarization and before repolarization; T wave, ventricular repolarization; QT interval, measures the total time for ventricular depolarization and repolarization. Normal sinus rhythm. Normal sinus rhythm means the electrical impulse originates from the SA node and follows the normal conduction pathway. Characteristics: regular rhythm, heart rate 60 to 100 normal P wave before every QRS. This rhythm provides adequate cardiac output and perfusion. Sinus bradycardia. Sinus bradycardia is a heart rate less than 60 beats per minute. Clients may be asymptomatic or symptomatic. Symptoms may include fatigue, dizziness, shortness of breath, chest pain, near syncope, mental status. Changes: safety concern, falls due to decreased perfusion. Causes of sinus bradycardia. Possible causes include medications, athletes, hypothyroidism, increased vagal tone, myocardial infarction. Labs and diagnostic studies for bradycardia. Important labs: electrolytes, thyroid hormone panel, troponin, toxicology testing. Nurses should assess pulse, interpret ECG monitor, vital signs, assess hemodynamic stability. Treatment of sinus bradycardia. Asymptomatic clients may only require observation. Unstable clients may require IV atropine, IV fluids. Transcutaneous pacemaker, atropine dose, 1 milligram IV every 3 to 5 minutes. Maximum total dose, 3 milligrams. NCLEX clue: symptomatic bradycardia plus hypotension may require pacing. Tachycardia is a heart rate greater than 100 beats per minute. Symptoms may include palpitations, dizziness, chest pain, shortness of breath, lightheadedness, fever, hypotension. Causes of sinus tachycardia. Common causes: fever, dehydration, pain, stress, anxiety, infection, medications, nursing interventions for tachycardia. Nurses should identify underlying cause, monitor ECG, monitor blood pressure, teach stress reduction, encourage hydration, reduce stimulants, teach vasovagal maneuvers if appropriate. Examples: bearing down, coughing, carotid massage by provider. Treatment for sinus tachycardia medications may include adenosine, metoprolol, beta blockers. Catheter ablation may be performed to destroy abnormal electrical pathways. Premature ventricular contractions. PVCs are early ventricular beats originating from irritated ventricular cells. Clients may feel palpitations, chest pain, shortness of breath, lightheadedness. Some clients have no symptoms. Causes of PVCs, possible causes: hypokalemia, hypomagnesemia, caffeine, alcohol, smoking, stress, cardiac disease. Diagnostic studies for PVCs, labs: potassium, magnesium, thyroid levels. Diagnostics: ECG, Holter monitor. Nursing care for PVCs. Nurses should analyze ECG monitor frequency and pattern assess contributing factors. Monitor cardiac output. Replace electrolytes if needed. Client teaching: stop smoking, avoid caffeine, avoid alcohol, avoid illicit drugs. PVC treatments, medications: beta blockers, flecainide, propafenone, amiodarone, catheter. Ablation may be used if medications fail. Premature atrial contractions. PACs are early beats originating in the atria. Most clients are asymptomatic. Some clients report fluttering sensation, palpitations, ECG findings, hidden or abnormal P wave, shortened PR interval. Nursing care for PACs. Nurses should identify triggers, review medications, encourage lifestyle modifications, reassure the client. Triggers may include stress, caffeine, alcohol, smoking. First-degree heart block. First-degree heart block occurs when conduction through the AV node is delayed. ECG finding, prolonged PR interval. Most clients are asymptomatic. Causes of first-degree heart block, possible causes: medications, coronary artery disease, electrolyte imbalance. Nurses should monitor ECG, review medications, assess vital signs, encourage healthy lifestyle modifications. Atrial fibrillation is an irregular, chaotic atrial rhythm. P waves are absent. The rhythm is irregularly irregular. The ventricular response may be rapid. Symptoms of atrial fibrillation. Symptoms include irregular pulse, palpitations, fatigue, dyspnea, shaster, dizzy, hypotension, syncope, complications, stroke, thrombus formation, heart failure. Diagnostic studies for atrial fibrillation labs: TSH, thyroxine, CBC, creatinine, glucose. INR diagnostics: echocardiogram, transesophageal echocardiogram. TE detects blood clots in the left atrium. Nursing care for atrial fibrillation. Nurses should assess pulse deficit, monitor ECG, monitor blood pressure, administer anticoagulants, administer antiarrhythmics, teach bleeding precautions, medication compliance, avoid stimulants, avoid herbal supplements. Treatment for atrial fibrillation treatments include anticoagulants, electrocardioversion, catheter ablation. Atrial flutter. Atrial flutter is similar to atrial fibrillation but produces organized rapid atrial contractions. Symptoms: palpitations, dizziness, hypotension. Dyspnea treatment is similar to atrial fibrillation: antiarrhythmics, anticoagulants, cardioversion. Supraventricular tachycardia. Supraventricular tachycardia, or SVT, is a rapid rhythm originating above the ventricles. Symptoms may begin suddenly. Symptoms include dizziness, hypotension, palpitations, syncope, shortness of breath. Nursing care for SVT. Nurses should monitor ECG, monitor blood pressure, maintain hemodynamic stability, assist with vagal maneuvers. SVT treatments. Vagal maneuvers may slow conduction through the AV node. Examples: bearing down, coughing medication, adenosine. Dose: 6 milligrams, rapid IV, push over 1 to 3 seconds. followed by 20 milliliters normal saline flush. If ineffective, 12 milligrams rapid IV push, followed by saline flush. Important: adenosine may briefly stop the heart. Have emergency equipment and defibrillator available. Other medications: IV diltiazem, IV esmolol, IV metoprolol. High-yield NCLEX review: S1 equals lub and marks systole, S2 equals dub and marks diastole, P-wave equals atrial depolarization, QRS complex equals ventricular depolarization, T-wave equals ventricular repolarization, bradycardia, slow rate less than 60, tachycardia, fast rate greater than 100, PVCs, think ventricular irritability, electrolyte imbalance, caffeine, atrial fibrillation, irregular rhythm with stroke risk, SVT, rapid rhythm treated with vagal maneuvers and adenosine. Adenosine. Rapid, I5, push, followed by flush. Atropine. Used for symptomatic bradycardia. End of lecture activity. Have students identify rhythm, interpretation, whether the rhythm is stable or unstable, priority nursing interventions, medications used, possible complications. Example: client with irregular rhythm, absent P waves, and stroke risk. Correct answer: atrial fibrillation.